This week on Inside Athletic Training, we welcome in Scott Stansbury, the minor league medical coordinator for the Baltimore Orioles. Scott talks us through his recent presentation on upper extremity evaluations, linking the findings to the condition. Enjoy the show. All right, Scott, welcome to Inside Athletic Training. I'm extremely excited to have you on for your second time on the show. This time will be a little different. We're going to start by letting you share some background information, your job or your title with the Orioles, and then we'll get into an upper extremity presentation that you shared with almost 200 students at the PBATS virtual athletic training symposium last Friday. So before we get into that, share with our listeners who didn't hear you on the first episode you were on a little bit about yourself and your role with the Baltimore Orioles.
Yeah, so this will be coming up on my fourth season. I'll be starting with the Orioles. I started here in 22 as a minor league medical coordinator. And prior to that, I spent a short period of time at my alma mater in Salisbury, Maryland, as the head athletic trainer. And then prior to that was 14 years with the baseball program at Notre Dame as the primary athletic trainer for that program. Assisted with football and some other sports as well. And then prior to that, did my grad school at Villanova. I was fortunate enough to stay there for 2 years after grad school. So that was kind of my first gig out of school. And as I mentioned, undergrad at Salisbury, graduated in 2003 and with a bachelor's in athletic training, and have been kind of cruising along ever since.
Yeah, that's awesome. You definitely have experience at numerous levels and a ton of experience in professional baseball as a minor league coordinator with the Orioles. You gave a great presentation last Friday during the Symposium for Students hosted by PBATS. Your main, objective of sharing information was upper extremity evaluation, linking the findings to the condition. As a former player myself and someone that works with you guys, so many issues in baseball when it comes to that. Walk us through kind of the key objectives and what information you thought was most important to share with the students last Friday.
Yeah, no, I appreciate that. It was a lot of fun to present this topic because I felt like this was a topic that you could really go any direction in talking about. But I felt like with the audience that we had, and really for everyone, like it was about, finding the way, as the topic says, linking the findings to the condition, like finding a way to bridge that gap. And specifically for students of like, hey, we've got all these findings. What do we do with it now? How do we get to this diagnosis or these diagnoses? And so that was really important to me to kind of figure out a way that would present the information that I wanted to present, but with knowing the audience that we had there. So some of the objectives were, initially just talk about the upper extremity diagnoses in baseball. What do we see commonly? I think there's, obviously a lot of people are familiar with Tommy Johns and slap injuries, slap tears, but some of the other things that I think, maybe get forgotten or maybe not forgotten, but just not as well known because they're not out in the media, so to speak.
Sure.
And then I wanted to kind of talk through like the process of the evaluation and really hone in on each part of the evaluation because I think each part in and of itself is really important to getting to the final result, right? And so that was an important piece for me. And then from that, like how do we take that process and put it all together to link up and make a good informed diagnosis and then eventually a treatment plan, which we didn't get too much into because this was about evaluation and not necessarily treatment, but it was really a way to, like I said, bridge that gap from all of the evaluation notes and things that students take in class, and they're getting all this information. And it's like, well, what do I do with all this? If I get all these answers, how do I piece all that together? So that was really kind of the goal of the presentation.
Yeah, and we'll get into, what you do with the information. You're obviously an expert and you can share that as we go along here. To start, there's so many common upper extremity diagnoses that, even the non-athletic trainer or the former player or just the normal person who watches the game hears very often,
Mhm.
shoulder impingement, obviously rotator cuff issues and strains and tears, elbow, wrist and hand. There's so much stuff going on. You did a great job of explaining kind of at a high level the overview of those issues that could be seen in the shoulder, the elbow, and the wrist and the hand. So I want to give you some time here to just kind of talk through some of the most common issues that you guys see.
Yeah, so the one thing about the upper extremity is there are so many, I mean there's so many things that could go on there.
Hmm.
And again, as you said, the commonplace person that just watches the game probably knows a few of these terms, but um when you get down to it, like some of these things can be coincide with each other, right? Like you can have some elbow and shoulder issues going on at the same time. You can have couple shoulder things going on at the same time. It's really about in the evaluation process digging into these conditions and try to nail down exactly what's going on. So for the shoulder, it's impingement. Slap tears again are probably some of the most common. I referred to biceps tendonitis because that's a term that gets kind of tossed around quite a bit, and
Hmm.
it may be biceps tendonitis, but it might also be maybe you have tendonitis because you have a slap tear, right? Because
Hmm.
something is tugging there. And so those were things that I wanted to kind of hone in on. Shoulder instability is another one. It's not very, you hear about it in football quite a bit, subluxations and dislocations, but you know, ironically, the game, what was it, game 4 of the World Series, Shohei ends up dislocating his shoulder, and
Hmm.
that comes out in the media, right? So it does happen in our sport. It's not a contact sport in a lot of ways, but it can happen. And so that's again a common thing that you see, or guys that have chronic instability just because of the stress that they've put on their arm over time. And so that's another one that people really don't think about quite a bit in the shoulder. And as you mentioned, the rotator cuff is common. I think we're seeing more lat injuries. You hear lat injuries a lot now in baseball. And I think some of that is we're getting better at diagnosing them. We're getting better at evaluating them, both with imaging and just getting our hands on guys. So that's really important to highlight. And then one that I think there was a question actually during the presentation in the Q&A that Dave answered, but somebody asked, one of the students asked what batter's shoulder was and kind of
Hmm.
what that means because he had never heard it before. And that's that chronic overload instability as a batter comes through his swing on the front shoulder of the player. So if they're right-handed, it's their left. If they're left-handed, it's usually their right. So anyway, that was a good one to throw in there too, especially at the shoulder, because again, that's something that it goes with the instability, but it's just a specific one to the baseball world. Um,
Sure.
and then, on the elbow, we talked about the UCL. I mean, I think you could probably talk for hours on that, and how prevalent that is in our game right now. But the other things like flexor strains, you hear flexor strain, and then maybe a few weeks later, you might hear UCL injury, and that's where you have to really nail down the diagnosis and go through a good solid evaluation. So I threw
Yep.
that in there because it does get thrown in with the UCL quite a bit. And then like bony injuries, like stress reactions, stress fractures, which doesn't specifically just occur at the elbow. It can certainly occur at the shoulder as well and the scapula, things like that. But kind of wanted to highlight those as the main ones at the elbow, because again, those are the most common ones that we see. And then in the hand and the wrist, like hitters typically are dealing with the hamate injuries. You hear that quite a bit. That's a
Hmm.
very common thing now, or the hook of hamate fracture. TFCC is the cartilage in the wrist, which that can be a little bit of inflammation, or you can have a tear in there. So it's kind of a variety of presentations with that. And then the common wrist sprains and strains. I don't think there's a sport that you probably don't have something like that or can have something like that with sprains and strains in the hand and fingers. But One thing that I highlighted, which I didn't really dig into too much, but it is certainly a condition that we evaluate is, blisters and skin conditions, specifically with, hitters on the palm. Pitchers
Hmm.
tend to get ones on their, index or middle finger, depending on how they grip the ball. And so again, that's something that it's not a orthopedic injury necessarily, but it is something that, we treat and we see, and we need to know how to evaluate and diagnose it appropriately. So.
Yeah, all very useful information for students, upcoming athletic trainers, and obviously people like you, practitioners who are doing this job every day. One thing that I kind of thought was interesting, or just kind of the phrasing of it, but was the itises that you mentioned.
Yeah.
So biceps, rotator cuff, flexor tendons, tricep tendon. Talk a bit about how that term was coined and kind of where that started.
Yeah. This was my slide on combination injuries, and I talked a little bit about, things that can be, together at the same time. I
Hmm.
started off talking about like nerve injuries and specifically thoracic outlet because that's another common thing that's going on right now. But the
Hmm.
itis was one that I really wanted to hammer, because I feel like I mentioned before, biceps tendonitis is a term that gets tossed around quite a bit. I kind of use it as like it can be used as a garbage term, so to speak, where it just gets thrown out there because we don't know what it is.
Hmm.
But really, at the end of the day, like this could be an itis could be a secondary problem to what's really going on. One of my professors long ago called it the cause of the pain. So the cause
Okay.
of the pain is maybe the biceps tendonitis, but what's causing that to happen? Is it the labrum? Is it the scapular position? What is going on there that's causing this tension on the biceps tendon that's again flaring that up. So I wanted to kind of illustrate that, a flexor tendonitis or a biceps tendonitis or a rotator cuff tendonitis in and of itself is a diagnosis, yes, but what else is going on there that maybe we can address? And going back to linking the findings to the condition, like really trying to hammer down, like, hey, if you have biceps tendonitis, you're going to see all these things on an evaluation,
Hmm.
but maybe one of those things gives you a clue that maybe it's something with the labrum too, and it's not just isolated to biceps tendonitis. Now, it certainly can be, but
Hmm.
very more often than not, it's going to be something else going on that's causing that. So that was something that I thought was really important, especially for the students to understand that it's not always just biceps tendonitis or flexor tendonitis. There might be something else going on there.
Yeah, that's very true and good thing to keep in mind there. One thing that a lot of you guys and men and women across the league and athletic training, um, talk about the trust and the relationships between athletic trainer and player and how important that is. One thing kind of when I was listening to you speak last Friday that I kind of thought about the trust and just that relationship was when you talked about the kind of the interview and gathering
Mhm.
history, about when you have a player with an upper extremity injury, you need to find background information, letting them talk, letting them tell you what's wrong, what they're feeling. Talk about the importance of that process with upper extremity issues. I know you don't want to jump in and say, all right, you have this injury, or I think you have that, or I think you're feeling this, but letting the player talk and listening to them and learning the history of their body. How important is that?
Yeah, I thought this was a really important. I felt like after I looked at it, I was like, wow, that's a really wordy slide. But I felt like in order to get my point across, I wanted to have all that information up on there. Um, yeah, I mean, I always have seen it, and as I've gotten older and more experience, you kind of start to let them tell you what's going on. You start to listen more, you listen better, become a better listener to what they're telling you. But that's a big thing for me is just kind of allowing them to, they're going to come to you anyway as an athletic trainer. They're going to come and say, hey, I've got this problem. Like, here's what's going on. And they may start just talking right away. Some guys will just let you know right away kind of what they think is
Hmm.
going on. Um, but it's good information because ultimately it gives you a starting point and it allows you to direct your questions a certain way, that lead you to more questions and more information that you're gathering as you're going through these, gathering the history. And so that for me, and I think I mentioned that in the talk was like use the answers that you get to then develop the next set of questions that you're going to ask or the next question that you might want to talk about. Um, so that's a really important piece for me. I think the history is at the end of the day, I think it's probably the most important piece, and I feel like a good history really allows you to hone the rest of your exam in a
Hmm.
way that you can get a good diagnosis, in a short period of time. It's not, in education, and it's not a bad thing because I went through it too back in the early 2000s. Like they teach you all of these things to test,
Hmm.
and it's like, well, if I have to do all of these tests for this one particular injury, that's going to take a lot of time. And
Sure.
so my point in that was like you can really hone in on which ones you want to do based on the questions that you're asking and the answers that you're receiving. Um, and, the other part is like getting to know them a little bit more, especially a new player that comes in or a new athlete. Like you don't know their history. You may not know anything about them. So understanding that, hey, they may have had this issue years ago and they never really did anything for it, or maybe they did things for it that helped them get better. And
Hmm.
so that was really important for me to address too, is like really get into like, hey, have you ever had any problems with this in the past? And then also, have you had any other problems, other areas of your body? Like sometimes the back can be a problem long term for people, and it ultimately causes upper extremity issues or lower extremity
Hmm.
issues for that matter. So, um, just getting a good idea. If you don't know their history, just assume that you don't. If you already know it, you can always ask the question to re-emphasize how important it is and like maybe get them to trigger, be like, oh yeah, I did have a back problem and then that led to this like before. So I like to use that as a really good like stepping stone and starting point. And then I just emphasize like taking your time, like don't be in a hurry to rush through the history.
Yep.
Um, and I'm not by any means am I not saying I'm good at this, but like I tend to now um, ask questions as I'm doing some exam because I think that's important to kind of again sometimes we're crunched for time and so it's easier to kind of talk through it as you're taking a look. But for students, I really felt like when you're starting out in this profession, it's really important to just take your time and be thorough as you can. And then the last point that I think I made was you know, be careful not to pigeonhole your exam. And if they say, well, I had this problem and they diagnosed it as biceps tendonitis, okay, well, that's what it must be. And then just go to that. Like you have to be careful about that as a young clinician. And then, asking other people who are involved in the player's care. That was another piece that I wanted to kind of throw at the end was you know, the strength coach might have more information for you. The position coach
Sure.
might have more information for you, especially on what their workload was or what they did or what they have been doing or what their, metrics are a big thing right now in our game. And so asking them like, hey, what did their velocity look like the last few
Hmm.
days? Or, things like that are important to know and can help drive some of your exam down the road.
Yeah, it's cool to hear how much goes into just getting started and having a conversation. We haven't even talked about any of the actual physical examination or imaging or working with a team physician, but just the starting point. There's a lot more that goes into it than I think a lot of people would imagine. And moving on to your next point was kind of discussing the physical examination. So um, I think from a cool perspective from you is talking about this in, to people that may never have done this before or students looking to get more information before maybe they give their first physical exam for an upper extremity injury. Um, to me, one thing that stood out was, not like you just said about focusing on the injury that you think may have occurred, also not focusing on the injured side of the body.
Yeah.
So making sure you're feeling and working on and examining the uninjured side is one huge piece of it. But talk about the physical exam and kind of maybe share some stories when you first started doing these and mistakes you
Yeah.
made, kind of how that process went for you.
Yeah. No, that's actually great. Yeah, for me, that was something that was hammered, as a young student. You're just told like always make sure you look at the other side.
Hmm.
Um, the cool part of the human body is it's fairly symmetrical. And so you should have a good idea of what normal is, especially for an upper extremity sport like baseball. Unless you're ambidextrous and can throw with both sides, um, that throwing side or that dominant side is going to be significantly different or could be significantly different than your non-dominant side. And we see that in some of our assessments that we do just in general. Um, in terms of strength, in terms of range of motion, different things like that. So I know personally for me, I know my shoulder external rotation on my dominant side is insane, and it's terrible on my non-dominant side because I've never done anything with my left arm. So anyway, but yeah, like that was an important piece, and then the other piece that I added to that was like starting away from wherever you're looking at. If it's the shoulder, like start down a lower part of the arm, start in the elbow, start in the wrist or hand if you want. Start away and work towards, because there is some hesitation in the player, especially if it's an acute injury or really flared up. They're not going to
Hmm.
want you to just go poking and prodding right away.
Yeah.
And so that was really important for me. And then, I talked about special tests, and I alluded to that earlier. Like there's a litany of special tests. There's a whole book. I think I tagged a book on the picture of the book on the slide, but there's a whole book of all these tests that you can do, and it's like, well, which one should I do? And the answer is like it should come from the rest of your exam or your rest of your exam, which starts with the history and goes through. And so you can really, like I said, you can hone in on which test you want to do. If you got time and you want to do all these tests, that's great. Just remember you got to document those on the back end. But yeah, that's really important. And for me, as a young clinician, well, as a student, one of the things that we were tasked with was being models for the students that were going through practical exams and different things.
Hmm.
And so for us to be able to be the patient and get poked and prodded, like we got a feel for what that would be like for a player. And then we ultimately have to do it. We would practice on each other, study sessions and things and try to get really good feel of what's different because everybody is so different. I mean, I'm super
Yeah.
skinny and I'm bony up in my shoulders, so I'm super easy to palpate. But
Hmm.
um, but some, bigger player may not be. We were always told like you're not going to be able to palpate a football player like you palpate a gymnast or a
Yeah.
swimmer. It's going to be different, and that's very true. And so that was a big, it was helpful when I was a student because again, you got the feel for that. And then it was more about, and I mentioned this in the talk, like the biggest point for me in the physical examination is you really have to know your anatomy. And that's something that is really hammered to athletic training students, and I think to all medical professions really. But in athletic training, it's like if you know your anatomy, the rest is super easy. If you know what
Yeah.
you're palpating for and what you're looking for, it makes the rest of whatever you're going to do super easy. And that's a really important point. And again, it goes with just anatomy and knowing, or not anatomy, but palpating, knowing how to do the range of motion testing, knowing how to do the strength testing, all of that is important, but the anatomy is like the base of that. Like you really got to know
Sure.
your anatomy to be able to hone the exam skills.
Hmm. And after the exam, you touched on physician referral and imaging. Huge part of what you guys do is working with team physicians. I believe that, when you're a young clinician just getting into the game, it's probably a bit intimidating meeting with the team physician. These are, medical
Yeah,
doctors
for
and
sure.
most very, very experienced, been in the game for a long time. Um, you know, Talk about your relationship with team physicians, how you guys work together, and also how you kind of found your groove, as a veteran now, working with those physicians and initially not being intimidated.
Yeah, no, I think intimidation is a good word there because I think as a young clinician, as you said, they're physicians. A lot of the physicians have been at it for a long time. Um, and especially ones that are team physicians for institutions or
Hmm.
teams. And so there is an intimidation factor there. I know as a young GA, one thing that I really pushed for, and I worked at Villanova and we were close to Philadelphia and working baseball there, I was very much like I wasn't opposed to our team docs that were there at the time looking at our baseball guys, but none of them really had the baseball expertise or the baseball understanding. And so I actually had Dr. Sakati, who works with the
Yeah.
Phillies. I don't remember how the connection was made, but we got one of our players down to see him, and I went with that player to the appointment, and it was really great to just see a baseball physician evaluate a baseball player
Yeah.
and really give him a breakdown of what was going on. And we ended up using Dr. Sakati quite a bit after that during my time there. I'm not sure if they still do, but it was really helpful for me as a young clinician getting into baseball to have that experience and to observe a surgery with him and see
Yeah.
how he, treated players because ultimately that gave me a little bit of confidence. And I referenced confidence being really key because it gave me confidence. It wasn't like, oh, I know how to do everything that he's doing because I've watched him a few times. It was no, what I'm examining and what I'm finding in my exam is matching up with his. And so that was super important for me from a confidence perspective to be like, you know what you're doing, you know how to evaluate this, like continue to build on that. And so
Hmm.
that was what I was doing. And it was really good for me to experience that and then ultimately go to Notre Dame. I think the team physicians there orthopedically have been there for since the 40s. I think they've been the team
Okay.
physicians there, the orthopedic practice. And so again, guys that have been there a long time, super intimidating, football, the whole thing. They ultimately hired a guy who played football at Notre Dame, but did I think he did I can't remember if it was his medical school or his residency, but one of the two at Thomas Jefferson in Philadelphia under Dr. Sakati.
Wow.
And it was like a no-brainer for me. This guy ended up being our baseball and football team doc, and I have a lot of respect for him. He's a great friend of mine, Dr. Radigan, Brian Radigan, and him and I had a great relationship in my 14 years there. They hired him shortly after I got there, and it was one of those things where he felt confident enough in me to say, "Hey, doc, I need this," or I think this guy needs an MRI because of this. And he wouldn't even bat an eye. Like as we got longer in our time together, he wouldn't even bat an eye at it. He'd be like, "Yep, I'll have my staff call you. We'll get it set up." I'd like to see them after, obviously, and
Yeah.
obviously we would do that. But um, it was one of those things where that relationship grew because he was confident in me, but I was also very, confident in myself and my diagnoses, and he would confirm that for me when he would take a look at them, and so it became a great relationship. Um, and that's what I really wanted to show to the staff that like if you have confidence in what you're doing, the doctors will see that. They can see that they if you walk in and say, "Hey doc, I think he's got this and here are the reasons why," and that doctor confirms that diagnosis on his exam, it's a home run for you because no pun intended, but like it's a home run for you because you now have confirmed to him that like you know what you're looking for and you know how to examine this patient, thoroughly
Hmm.
and get to this diagnosis. And so as I've gone on and continued in my career, that's one of the things that I think is really important for anybody starting out is building a relationship with your team physicians, and understanding that they have a job to do too, and they're ultimately the, kind of signing off on our licensures and our different things. But, we have to work together with them, and they're going to be the ultimate sign off, right? They're going to be the decision maker. They might be the surgeon eventually, but ultimately, like a great relationship with them is a huge piece to the entire process. And so that's why I kind of mentioned in my talk, like, you want to give them the information, but they need to evaluate the patient too, and
Yeah.
give them the chance to do that. And I think it's just really important. And as I said, like as the relationship grows, your experience grows, like things get better, things get easier. I was just on the phone the other day with our team doc about just talking through a handful of things that we have going on in the off season, and it was like,
Mm-hmm.
what are your thoughts here? Here are my thoughts. And just having that ability to have a conversation. It's not me dictating to them. It's not them dictating to me. It's a professional conversation, and I think that goes a long way in helping the player get the best care possible.
Mm-hmm. I think what's really interesting from a student perspective is, and a theme I kind of drew from your entire presentation was just the confidence that it takes to succeed in a role as an athletic trainer at the minor league or major league level, even in college. Starting with the history and the exam that you put together, but going into your meeting with the team doc and showing complete confidence that you've made a good assessment of the injury and you know what's going on, ultimately leading to you guys making a decision based on and kind of confirming what you thought, and
Mhm.
not like being right is always the answer, but of course being right and knowledgeable is important for a young athletic trainer and to breed that confidence. So I thought overall being confident and not intimidated by the situations and the environment was a huge takeaway for me. A huge portion of the process here is, what do you do now? So you
Yeah.
talked about and that's where you're such a specialist now is obviously the anatomy is key. You know what you're looking for, you understand how the process works, but what do you do with this information once you have, I guess, quote unquote, a formal diagnosis? So could be a minor injury or a major injury. Talk a bit about the process after diagnosis is confirmed. You guys are all on the same page, team doc and athletic trainer, everyone involved. What are the next steps?
Yeah. So, yeah, I mean, I think if you, as I mentioned in the talk, like if you have a really good history and your exam's good and the physician has confirmed, or maybe has confirmed your assessment, but also maybe has added their own assessment to it,
Yeah.
that maybe they have something else going on that maybe you didn't miss, but maybe you were just not thinking in those terms. But once you've gotten to that point, I think it's important to just have a plan in terms of one, messaging that information out to whoever needs it, specifically obviously the player, but maybe to the coaching staff, or in baseball's case, to the front office, so that they're aware, kept in the loop on what's happening and what's going on. But then it comes down to like treatment and how do we address issues treatment wise. One of the things for me is like um, just having a good plan and executing that plan, and being able to be adaptable and change that plan if necessary. I think one of the things that I kind of talked about was like in a minor injury, it should be really easy, right? Like, hey, this is let's just use it, biceps tendonitis, and that's really all it is. You can easily treat that with modalities and exercise and a good throwing program, and probably get the player back in a reasonable amount of time. And so having that treatment plan, mapping that plan out, and executing that for the player. When it's a major injury, something that might be require some surgical intervention, or PRP or any type of intervention like that, I think it's important to just map out that entire plan to the player, sometimes to the front office if we need to, for timing purposes. But in general, like mapping that out for the player and giving them a timeline, like, hey, like this is what we expect at this mark, this is what we expect at this mark.
Mm-hmm.
And I think that helps in the beginning, because it does settle the player down a little bit. It does allow them to kind of process and say, hey, they know what to expect now. Short-term injuries are what they are, short term, and they know what to expect. Long-term injuries are a little different, and so you have to really have a good plan. I keep using that word, but it's true. And then, from that, just looking at one of the things that I mentioned was like, is there anything else that we can do or add to this, or should we look at other things while we're treating this particular injury? And I think it goes back to the original thing I mentioned in the history. Like if they have a back problem historically, maybe that's your time to work on that. And I didn't really mention that in the talk, but I'll mention it now. Like that, for me, like that's another piece. And I will say, like, I've worked with a lot of people that do that really well. They identify other problems that
Hmm.
may not be as highlighted because it's specific to a shoulder or whatever. But maybe they've had a back problem ongoing for 2 or 3 years that they never really said anything about. But it
Hmm.
goes back to what you said in the beginning. Trust. They trust us. They trust us to take care of them. And they may mention, hey, I've got this back problem that's been bothering me too. Like, do you mind if I take a look at that, or we take a look at that, or address that?
Yeah.
And excuse me. So that's kind of the next piece for me is like you gotta have a next step, you gotta have a next plan, and prepare to address anything that might come along the way.
Hmm. And one thing that kind of caught my eye, listening to you last week, was actually the post treatment processes. So obviously we talked through learning about the athlete, figuring out things about the injury, um, working with team physicians, putting together a plan. Um, so if it's a minor injury or even major for that matter, when the athlete's back on the field, they're 100% healed, they're healthy, they're playing. How do you handle the kind of monitoring, if that's the right word, and making sure there's no reoccurrence, or do you need to be repeating exams periodically? How often to do that? Should I be afraid because I don't want to, you know, make it seem to the athlete like things are maybe worsening? How do you handle that kind of monitoring phase after the athlete is back and the treatment plan has been successful?
Yeah, I think one of the things that I brought up was kind of answering the questions of like, have they have they addressed all of the deficits that you found in your exam?
Yep.
And the only way in that initial exam, right? And so the only way to really know that is you do need to reassess towards the end. Now you don't have to go through the whole history again. You know their history at this point.
Hmm.
So it's more about the physical exam, identifying any of the deficits, specifically range of motion, strength, palpation, even like if you're palpating the shoulder and they're not tender anymore, that's a good sign. Um, for special tests, are they negative now in their testing findings? Finding, negative findings, no pain, no instability, different, things that we're looking for there. So answering those questions is really important, but you can certainly reassess periodically as they're going through the treatment plan too. I felt that was an important point to make was like you don't just have to do this first exam and then that's the last time that you touch the player in terms of an exam.
Hmm.
Um, so reassessing periodically, and then as they get to the end, checking have they checked all the boxes in terms of their treatment plan, but now have they checked all the boxes in terms of what their deficits were and or what their negative findings were or positive findings were. And if they do, then you kind of let them go, and they've kind of checked the boxes for
Yeah.
you as a clinician. Um, but in terms of monitoring, like we're not pulling guys in just to take a look at their injury or look at
Yeah. Just to
reassess
do
their
it.
shoulder. But what we do try to do is provide them with a maintenance plan to address those deficits and continue to work on those things that got them to the point where they were hurt before and had to miss time. And that's a really important piece in our program is to give these guys the opportunity and we make it so that it's self-sufficient. They're very self-sufficient. It's not directing them to do a certain
Hmm.
thing. It's like, hey, these guys make this part of their routine. I tell guys all the time, make it part of, you have to put your uniform on every day. So just make it like putting on your uniform. This is part of
Yeah.
putting on your uniform is coming in and doing your maintenance work. And I think that's a really good like thought process to have. Like it's part of your uniform. I don't remember who told me that years ago, but it was a good one that stuck with me.
Yeah.
Um, and and so that's kind of how we address it with just building out a maintenance plan that is very similar to what they did in treatment and rehab, but now you don't have to do it every day. It might be every other day or days that you have higher volume or whatever the case may be.
Hmm.
It's certainly a way to keep track and keep tabs on them as they go through.
Hmm. Yeah, and to wrap up here, Scott, all this information has been awesome for students and for any clinician or professional out there. You talked a little bit about the anatomy being just the key foundation of what athletic trainers do. And we walk through the process here of, upper extremity injuries and how you handle those within your organization. Outside of the stuff we talked about, is there any key takeaways that maybe you wish you would have known when you were a student or during your time at Notre Dame before professional baseball? Any kind of key takeaways that you'd like to share with the listeners here?
Yeah, one thing that I touched on in the talk was, at the end of the day, you have to be able to answer the questions that are in your mind as a clinician. And so for me, it's like if you get stuck on something, or this particular evaluation leads you down a really muddy road or cloudy road, however you want to term it, where you're not really sure what the condition is. Ask yourself, like, what's missing? What am I missing? Did I miss anything in my evaluation? And that's where the doctors come in, because you can always ask them, like, hey, doc, like, did I miss something here? Or like after they've obviously seen the patient and you have time to,
Mm-hmm.
circle up with them, like, hey, did I miss something, or what did I not give you in terms of my evaluation that would have helped you? So asking yourself those questions, and if you don't know the answer or you're not able to answer that question, those questions, don't be afraid to ask for help as a young clinician. I think that's something that is really important for anyone, but specifically in athletic training. Don't be afraid. There's a lot of us that have been through a lot and have seen a lot, and I wish I would have relied on some of my older colleagues and people that I knew um, earlier in my career. But it's something that you have to learn to do, and it's certainly a learned skill. But just asking for help. And then the other thing I mentioned, and I didn't talk about it earlier, but with the physician, with the relationship of the physician, I think one thing that's really important for young clinicians is, like, once you have a chance to work with them, if you're new with a physician, like, and they say, hey, I want to do an MRI on this, but everything that you've been taught has been like, no, we typically just do an X-ray, or
Yep.
maybe it's a CT scan, or maybe it's MRI and CT, whatever. Just having a conversation with the physician or with your colleagues to say, hey, why did you, in this particular case, why did you order a CT and an MRI instead of just an MRI? And I still ask that question sometimes. I'll ask our docs sometimes about that. Um, just knowing the circumstances surrounding the injury. Hey, why are we doing this differently than that, or whatever it might be? So I think at the end of the day, I think a real big takeaway is, asking questions, and don't be afraid to ask for help when you're stuck on something. If an exam really, really pins you up and you're like, I have no idea what this is. Um, don't be afraid to have somebody else take a look. Say, hey, do you mind getting a set of eyes on this and taking a look at this, and and
Yeah.
and asking, and asking them what they think. And maybe if that person and you are really on two ends of the spectrum in terms of the injury, well, then maybe there is something missing, or maybe there's something that we're not getting. Um, but if you guys are close in terms of in terms of the assessment, maybe you didn't miss anything. Maybe it's just a funky case that you're going to see a few times in your career too.
Yep.
So that's a big piece for me. And again, I think I just said, like, just be careful about how often you're examining these guys. They don't like to be poked and prodded a ton.
Yeah.
And so, like, be careful, take your time, but be efficient with how you're approaching this exam. Um and ultimately, the more that you do it, I don't know if I mentioned this in the talk, but the more that you do these things, the more often you do them, the more confident you get, the more comfortable you get in
Mm-hmm.
examining and making a diagnosis that is probably pretty close to what the ultimate final diagnosis is.
Yeah.
And so that's important. Like, it does take time. It's not something that happens overnight. You don't become a good clinician overnight. But the time and the experience and doing doing your research, going back and looking, did I miss something? Those are all really important things to do as a young clinician.
Yeah, I think just listening to you talk there and wrap things up today, goes to show how important teamwork is in the sports medicine department. You're not there alone. You're not making decisions on your own, especially in your position.
Yeah.
Touch on so many different affiliates up to the big league level and so forth. So working with the team docs and the head athletic trainer at the big league level, and there's always a second opinion that is probably good to get.
Yeah.
And
Yeah.
asking questions and really remaining curious is something that's important within the profession. I think you kind of pinpointed that there. Well, Scott, this has been awesome information for the students and people across the league to hear from you. Always appreciate you coming on Inside Athletic Training to share your knowledge and all your experiences, and we hope to have you on again soon.
Yeah, Sam, thanks a lot for the time, man. Really appreciate it. This was fun.
Thank you for listening to the Inside Athletic Training Podcast. For more information about PBATS and athletic training, visit PBATS.com.